Hello, my name is Jennifer Lightdale, and I am a pediatric gastroenterologist. And this talk is called A Show of Force, Diagnosing and Managing Vomiting in Children. And I really have no relevant disclosures to this talk and won't be discussing anything unapproved or investigative. What I will do is start my talk by reminiscing about a really wonderful pre-COVID vacation I took in 2018 with my two kids to visit my aunt and uncle who had retired to the Big Island in Hawaii. And it was really our first time visiting them and visiting Hawaii. And it was a truly amazing trip. And one of the things we did was go to the national park to see the volcanoes. Or the volcano and on the Big Island. And I will tell you that my uncle, who's this wonderful scientist and always filled with facts, commented that we were incredibly lucky because we could really see the volcano from the viewing platform, which apparently is not usual at all. In fact, he was really sort of wondering at that. And of course, I think if we'd been able to be a little closer, it might have looked like this. What we, none of us knew, but within 24 to 48 hours of returning back to Massachusetts, we woke up to the news that the volcano had erupted and really had shocked Hawaii. Luckily, at that point, we understood the Big Island is actually quite big, and my aunt and uncle live in Kona, so quite far away from the volcano. But it was still explained why we could see it, maybe. I do think that this discussion about volcanoes is a wonderful way to also think about vomiting, which of course is a common symptom of numerous conditions in children. Certainly when children vomit and people are worried about vomiting, they think about the gastrointestinal tract, so they call us. But of course, we always remind everyone that it's often a symptom of generalized systemic disorders like a virus. It's usually benign, and so you can manage most vomiting in children with supportive measures only. But I think in a setting like in an AAP practical pediatrics course, it's really important to drive home that there are life-threatening causes of vomiting. And we do need everyone, all clinicians, able to recognize them. And of course, there can be serious associated complications of vomiting, like electrolyte abnormalities, dehydration, and even bowel necrosis from the dehydration. So it's very important to recognize what's happening and to treat if necessary or to refer for treatment. So the objectives of this talk are really to describe various presentations of vomiting in infants and children. I'm going to go over what we understand about 4 physiological pathways that can trigger vomiting. I like to make sure whenever I can that I talk about bilious emesis in the newborn as an indication of bowel obstruction, and really to recognize that when you see green, bright green, neon green emesis in a newborn, you have to take it incredibly seriously. And then also to identify cyclical episodes of vomiting in children as not necessarily life-threatening, but something that's more common than people realize, and that is often consistent with migraine variant. So to really recognize vomiting can be a migraine variant. So if you think about the anatomy of a volcano, it looks remarkably like the anatomy of the human gastrointestinal tract, where we have, basically the stomach leading into our conduit or our esophagus. And just like with a volcano, there's a lot going on underground. Also, like volcanoes, vomiting can be very unpredictable. And this is a wonderful photograph just caught because he was pressing take photos and he got more than one. My colleague got more than one photo of his daughter and boop, she vomited. So we all use this to just talk about how you can capture it sometimes on film. Usually it's preceded by hints. So when you really look, you actually realize there were some hints. It can be at that moment that you're seeing symptoms and signs of it, like profuse salivation or sweating or tachycardia, nausea. There's often, with both acute and chronic vomiting, there's going to be afferent innervation of various organs, and then efferent relaxation of other organs that lets the vomiting happen. And actually, when you look back at that Hawaii, they were all realizing they had been having a series of cracks in the highways and on the streets, that people sort of were saying, oh, we just seem to be having a year with lots of cracks, but that was perhaps the hints that the vomiting was coming. So the other thing that's really important, I think, is to be very precise with your definitions of what terms you're using around stuff coming out of the mouth. So vomiting is really a forceful expulsion of gastric contents through the mouth and or nose. And it's really a very violent experience. I'm going to talk more about that. And that's very different from reflux or regurgitation, which is basically effortless retrograde flow of gastric contents into the mouth. And it just doesn't involve any like violence to it. Rumination, intriguingly, is not effortless. There's actually almost a skill involved with rumination, although patients often don't realize they're doing it, but they're actually like clenching various abdominal muscles. And it involves regurgitating and rechewing and swallowing your food. And believe it or not, kids do this more than we realize. So really probing for, can you make yourself do that, is helpful sometimes if you're thinking about rumination. But that's very, very different from vomiting, which is uncontrolled and very forceful and violent. So why do we vomit? It's so unpleasant. You say, well, why do we have to do this? And the answer is we clearly have these primitive reflexes, the emetic reflex in particular, which seems to be a neuropathic process for the body to protect itself, probably against toxins and other triggers. It is evolutionary, so most vertebrates vomit. You can watch your pet do it. And it's clearly protective. So it clearly helps with food poisoning. And there's a lot of interesting theories around pregnancy and appetite suppression. And maybe it's not so terrible that people vomit, at least from a protection of the species standpoint, but it's really miserable, obviously, if it's affecting you in pregnancy. In terms of the defining features, again, vomiting is violent, it's involuntary, it's the somatomotor event, and it's triggered really centrally in the midbrain. It's really quite a primitive reflex. Nausea is a much more high cortical experience, so much higher up, and they aren't necessarily connected. So you have a lot of conditions with chronic nausea that actually will never lead to vomiting, and a lot of vomiting that had no nausea prodrome. So they're not necessarily connected. They both can involve neurotransmitters, and the neurotransmitters associated with vomiting in particular, we know, are neurokinin, dopamine, serotonin, histamine, motilin, and again, even some subtle stuff within that. So 2 different types of dopamine, 2 different types of serotonin, et cetera. But there's clearly a chemical trigger going on. And we really think that those neurotransmitters are actually very important for the pathways to vomiting that seem to make it happen. So the first of the 4 main pathways to vomiting involves mechanoreceptors or chemoreceptors in the intestinal wall that get stretched or stimulated, and that can cause your abdominal vagal afferents to send signals to the vomiting, what they call the central processing unit. And so this can happen with a virus or with bowel obstruction, where you basically get stretching or stimulation in the GI tract that's basically triggering the vomiting. That's different from blood-borne toxins, so something in the blood that's directly stimulating the chemoreceptor trigger zone that's involved with the central processing unit, and this is not protected by blood-brain barrier because it's midbrain. And so this is probably the way a lot of drugs work, and may also be the way the migraines work. Motion is a really interesting one. Your vestibular system definitely has a number of different neurotransmitters that can be stimulated and start signaling with abnormal movements or irritation. So you can see this with car sickness or ear infections. And then fascinatingly, emotions. So a lot of cortisol, they have these higher cortical pathways, intense emotions can definitely trigger vomiting. And as I was saying, they all sort of refer their signals to what's called the central processing unit, which triggers the emetic reflex. And this is really a midbrain phenomena where you really have very little cortical control over it. Nausea is much higher up in the amygdala, but actually can sometimes be sending neurotransmitters also down into the central processing unit. So the central processing unit triggers this emetic reflex when it receives an afferent stimulus by one of these pathways. And then it sort of sets off this series of events, which I think are dramatic and violent when you think about them. So I'm going to just describe it. And I will tell you, I've had the misery of having food poisoning a couple of years ago as I was writing a review on vomiting for the AAP with my colleague Matt Shields, who gave me the picture of his daughter. But mine was a much more miserable food poisoning, and I found myself thinking about what was happening. So we're going to go through what happens. So basically, you know, you've got something triggering the vomiting, and what the central processing unit does is it sends vagus nerve efferents down to the distal small intestine, so pretty far down, and it causes what's called a giant retrograde contraction of your distal small intestine. And that sort of, you know, what you're going to feel diaphoretic and tachycardia. It's a really miserable experience to have this giant retrograde contraction, and it will actually start you retching. And with retching, you have closure of various things that are now going to help pressure build up. So your upper esophageal sphincter and your glottis in the back of your throat is going to close, and then your diaphragm and abdominal muscles are going to contract, and you'll get all of this intra-abdominal pressure. Meanwhile, your esophagus is initially contracting, and then it just massively dilates, and that sort of pulls up the stomach into the thoracic cavity, and you basically lose your lower esophageal sphincter property. So you have nothing really keeping the stomach contents in the stomach, because now your stomach's in your chest. And basically you're getting this like very violent, dramatic experience. And it's really a cycle of retching that's going to repeat itself until you've expelled what's in the stomach. It's always extraordinary because you feel like, oh my God, I have nothing left in my stomach. How can I keep bringing stuff up? And you have to remember, it's actually stuff is moving from the small intestine back into the stomach. And then bringing more up. So real food poisoning will not just be, did I empty my stomach? It's, did I empty my entire small intestine? The body is quite intent on getting all of it out. And again, just to, you know, make that very clear, that this intestinal pressure really is starting with this giant retrograde contraction quite distal to the stomach to bring whatever it's trying to expel into the stomach. And then you know, it's really the stomach moving into the chest and the esophagus sort of pulling it up, where you're really having this violent vomiting. And it is just very violent. So, you know, I think when we think about vomiting, it's important to characterize it by symptom pattern. So in acute vomiting, those symptoms, those events are really happening over a period of a few hours, and you're just repeatedly vomiting, you know, and you may actually develop dehydration. That can respond to antiemetic agents. And I would say viral gastroenteritis or food poisoning is sort of your classic here. Chronic vomiting is really the concept that you have this vomiting, it's violent, but it's happening less frequently, just happening more often. So several days to weeks that it's going on. So it's frequent low volume vomiting. That won't usually respond to antiemetics. I see a lot of kids who have really a story of chronic vomiting who've been given, you know, ondansetron, and it's not necessarily going to help them. And sort of classic here is peptic ulcer disease or Crohn's disease. It's not really going to help you. And then you have these cyclical vomiting situations with these recurrent bouts, then interspersed with these periods where you have no symptoms at all. You feel perfectly great. So certainly when you're having the bout of vomiting, dehydration is possible, but when you're feeling well, you're feeling well. And it's not clear that antiemetics will help because of, again, we don't fully understand migraines. We don't fully understand what's making it happen. But cyclical episodes, you know, again, are less likely to respond to antiemetics. So I think it's important to think about your differential diagnosis by those patterns, but also by ages. And I'm just going to put this slide out here, and you all should study it, you know, when you have time, or keep it somewhere for yourself. But certainly what causes acute vomiting in a 1-month-old is quite different from what you have to think about in older school age kids. So what about red flag signs and symptoms? These are probably across the whole board useful. And of course, the number one thing people call me for is they saw blood. So hematemesis gets people's attention, certainly a red flag. And I will tell you, it's most exciting to me if it's the first thing that happened. The first thing that happened is you erupted with this very dramatic, you know, vomiting of blood, and enough blood that you can show me that you lost blood. So you seem anemic, you've got symptoms of that. You know, when you've had repeated emesis and retching, like I was describing with my food poisoning, You may have hematemesis after a while, and that's called a Mallory-Weiss tear. And that's really because this vomiting is so violent, it does cause little tears. And I'll show you a picture of one in a second. So that doesn't excite me that much. You've had repeated retching, and now you had a little bit of emesis, blood. Okay, now I know you're really vomiting, but it's the blood itself is not a problem. Bilious emesis gets my attention. Bilious emesis implies that it's something distal to the stomach, and it could be something related to obstruction. So should be taken notice of, and certainly in infants is a big story. So we'll keep talking about that. You also want to pay attention to anything outside of the stomach. Have they had recent issues with neurological deficits? Are there signs of peritonitis? And then I think one thing that'll get our attention is that the child is being waked from sleep. And again, that may help you to sort of pinpoint what it is, because cyclical vomiting, believe it or not, mostly is a middle of the night phenomena where it wakes the child from sleep. But certainly in the setting of, and they've seen more clumsy, or they've been having new symptoms of headache or other issues or loss of appetite or things like that, you may need to consider, could there be an intracranial presence of an intracranial mass? So it's important to document absence of these in your note, or at least to consider them. So consider red flag signs and symptoms. So in terms of that Mallory-Weiss tear, as I said, yes, I think vomiting is very violent, and it can lead to gastric bruising. And you can see these small superficial mucosal tears. So this is what one looks like close up. And you'll really see it in the distal esophagus, right where that lower esophageal sphincter is being sort of really put through a lot. And so it's really usually visible bright red blood, and this will heal very quickly. This is very superficial, won't cause any significant blood loss. So with neonates and infants, again, any forceful repeated vomiting, I'm going to say that's not normal and needs to be taken seriously. But for sure, you're 1 month, 2 months of age, and you are having bilious emesis, so bright green emesis, I want to treat that as life-threatening. And it's really incumbent upon you to consider GI obstruction. There's some really classic obstructive phenomena that can affect infants, and we'll go through these. And then there's also systemic and extraintestinal issues like sepsis or increased intracranial pressure or inborn errors of metabolism, many of which you could pick up on the newborn screen. So it's really important to go back and make sure you got that back on that infant, and did you see it? And of course, then there's all this benign causes like gastroesophageal reflux and overfeeding. So, I think you need to, in a newborn and an infant, you want to listen, and you want to do some quick deciding, am I worried? Is it bilious? And do I have anything else that would make me worried? So what are you worrying about? So these are some common syndromes. So pyloric stenosis is actually a fairly common surgical disorder in neonates. We don't fully understand why it happens, but the pylorus, which is a muscle at the drain of the stomach that sort of opens and closes and allows the stomach to empty, can become hypertrophied. It seems to be a nitric oxide phenomena. And this is showing an ultrasound picture, so it should be wide open, and instead it's quite stenosed here. This condition only occurs in newborns, usually between 3 and 6 months of age, and presents often with projectile vomiting and weight loss because nothing can get out of the stomach. And these kids get electrolyte deranged. So you really want to be checking electrolytes. That's very different from duodenal atresia, which is less common, but fortunately tends to present at birth. So these are babies who have bilious emesis within the first few hours of life. And they often have other things going on. So Down syndrome or congenital heart disease, or you may stumble into malrotation, but the other two you may already be aware of. With duodenal atresia, the classic is you get you'll get an x-ray of the baby, the whole x-ray, of course, because these infants, you can't just get the chest, you're gonna get the whole thing. And what you'll see is the famous double bubble. So this is the stomach, and this is the duodenum, and the duodenum is all dilated because it actually is obstructed. Malrotation is very common. So malrotation, where you have this abnormal intestinal rotation that occurred during gestation very early on in the first trimester, and you have aberrant fixation of ligament of Treitz, which actually is supposed to tack down the duodenum and jejunum in your left upper quadrant, and instead it's somewhere else. That actually occurs in about 1 to 2% of the population, and most people are asymptomatic, never even know they have it, and it gets diagnosed incidentally on CT, abdominal ultrasound, upper GI series, or even mostly it's cadaveric studies that have made it so clear to us that this is mostly an asymptomatic, lifelong condition that people won't know they have. But it can set you up for intermittent volvulus, so twisting, because of how your ligament of Treitz is fixed, and it may actually put you at risk for twisting of your intestines. And if that happens, you may see bilious emesis, and then if the twisting can't untwist, you can get abdominal distension, peritonitis, small bowel obstruction, basically, and of course, it's life-threatening. So these are pictures of malrotation. This is sort of a classic way to go at it with an upper GI with water-soluble contrast. And what you're seeing here is the small intestine should flow back across the spine and be tacked down over here. And instead, it never does that. It's malrotated. It's all over here. And this is a KUV just showing what real volvulus might look like. Here's an upper GI showing twisting. But this is volvulus. This is life-threatening, and it's basically twisting of the intestines on the mesenteric axis. And you must think about this in the infant or child with bilious emesis. And then intussusception. So intussusception is about 1 in 2,000 infants and children. It can really occur at any age, but sort of there are all these adages. So it's most common in children younger than 2, commonly 3 months to 3 years. We talk about it as idiopathic, but there's probably lymphoid tissue that's serving as a lead point, a way by which the intestine can essentially invaginate in on itself, and then can often spontaneously undo itself, but then can re-intussuscept. It can involve any section of the bowel, but it's usually the ileum into the colon. Ileocolic is the most common place. And certainly if the bowel cannot decompress, it can actually become ischemic, and that can be life-threatening. So the classic presentation of intussusception is what they call the classic triad. So the child, while the intussusception is happening, is having terrible pain, they're vomiting, and then they're passing what they call current jelly stool, which is basically just sloughing of the mucosa. So it's like a big bloody mess. But the truth is, a lot of infants don't present that way. So, be careful looking always for a classic triad. And instead, if you're wondering, sort of having these intermittent episodes of pain, you want to try to understand, was there a preceding, infection? Or it might be a GI infection, could be a cold. Do they seem to have like periods where they're terribly in pain and then they're okay? And then with infants, do they just act like they're in shock? So they can actually be not so colicky. They might be lethargic and just lying there and letting you examine them almost too well. And, until there's actually ischemia, you may not have peritonitis signs. And instead, you may be able to do a very good exam. Again, on an infant who's letting you do that exam, I would be worried. And they talk about you might feel the sausage-like mass of the intussusception. Obviously, that's not that common, but something to be aware of. And of course, what do you want to do? You want to do imaging. So imaging might be an ultrasound or a CT or an air contrast enema, which is not just a way to see the intussusception, but actually to get it to decompress. So these are classic signs. With a KUB, you might see what they call the target sign or crescent sign of where the intussusception is. This is an ultrasound where you can clearly see it happening. And then this is actually a surgical picture showing this very dramatic intussusception occurring, which is definitely life-threatening if it won't decompress. And then I want to talk about Hirschsprung's disease, which is actually a colonic condition. Hirschsprung's is 1 in 5,000 births, so certainly can occur. You have a colon and it's in the right place, but you're missing the nerve cells, the ganglion cells, and it's at least in some of the colon, and sometimes it's all of the colon. And it might just be the rectum, or it might extend proximally, and again, it can be a total colonic Hirschsprung's. The infant, intriguingly, even if it's just the rectum, may present, the number one presenting sign may be bilious emesis. And the issue here is that the colon's not moving. So it's essentially serving as a functional obstruction, and they're having emesis because the colon can't actually evacuate anything. And you diagnose this with water-soluble contrast enema. which is different from intussusception, but it's also hint, the question in the MOC testing for this course. So, diagnosis of Hirschsprung's disease with water-soluble contrast enema in an infant with bilious emesis that you can't understand. And what does that look like? Well, on a KUB, you just see like this massive, large bowel obstruction. But what the enema may show you is this narrower piece and then this very dilated piece. And the very dilated piece of colon is actually the normal colon. It actually can extend, but you have a transition zone, what they call this, and you have this very narrow piece, which or looks like normal caliber, but it's not distending, and that's because it's missing the ganglion cells. So the egg ganglionic section is actually the thinner section, and then this is the section that's more normal, so it's able to distend. Okay, what about reflux? So reflux is not life-threatening, and it's the topic of another talk in this course, so I won't get into this too much. You see it peak at about 3 to 4 months of age, and then gets a lot better after 6 months of age. And it certainly can be frequent, and it's basically all gone by 12 months of age. And it has to do really with physiology. We're just designed to reflux, but in infants, you have this very short esophagus and a smaller stomach, and you have no gravity helping you because you're not sitting up, you're lying down. So that is why reflux is so common in infants. But parents will really use the term reflux and vomiting interchangeably. So I think it's incumbent upon us to ask them questions so we can figure out what they're trying to tell us. I think reflux is effortless. It can be associated with distress. The baby may be unhappy, but it's not a forceful, violent event like I was describing vomiting. Certainly if there's poor weight gain or they're distressed, you certainly should consider a pathological GERD, so reflux disease, but that still doesn't make it vomiting. So, people will use the terms interchangeably, but vomiting is really a very forceful and violent experience. So, what should you do if someone tells you their child is vomiting? I think it's really pinpoint. Are they actually describing vomiting? And then if they are, if it's prolonged, repeated episodes of retching and vomiting, really regardless of what color it is, so I don't care if it's bilious or bloody, at this point, just the fact that they're continually retching, now I start to worry for sequelae of vomiting, complications of vomiting, dehydration. I want to figure out why this is going on. So for sure, more than 12 hours in a newborn, you got to start evaluating. So that newborns are not supposed to vomit that much. At all, actually, but really for more than 12 hours, you need to sort that out. And then if it's been going on for more than 24 hours and they're less than 2, take that seriously. They are at high risk for dehydration. And then more than 2 days in older children, I think, is a good rule of thumb. And what should you do? Well, you should certainly investigate whether they might have an infection or obstruction or terrible something going on that you can manage, and there's all kinds of ways to think about what the CBC may tell you. You certainly want to look for electrolyte imbalances and to understand what could be going on and or what you need to correct. You do want to think about pancreatitis and hepatitis and hepatobiliary diseases. You can get an x-ray to rule out obstruction. You consider fluoroscopy to think about anatomy in the right situation. If it's appropriate, you may want to do head imaging. You may want to do abdominal ultrasound. Again, depends on what you're thinking about. That'll sort of guide what you're asking. And some of that is the age of the patient. And then there's endoscopy. So endoscopy is useful for looking for inflammation, irritation, or infection. It generally is not going to tell you the source of acute repeated emesis that brought somebody in. And really, again, that's really the key. I think I want you to think about what's the pattern I'm dealing with. What do I need to be sorting out? Are they obstructed and might they have electrolyte abnormalities if it's acute? If it's chronic, could there be something underlying that I need to think about? And then cyclical vomiting, especially in younger kids. Am I at 100% sure this is just cyclical vomiting? Very young kids, you want to go back and think about, could this be a subtle metabolic defect? So these are kids at the moment of the distress before you rehydrate them. That may be when you need to think about a metabolic panel that gives you more information. So, you want to use clues on your history and physical to narrow down your diagnosis or your differential diagnosis. And certainly, again, that may depend on your age. And I've given some thoughts here on that. And I just wanted to talk about a couple of conditions that affect older kids that are more associated with chronic vomiting. So one is eosinophilic esophagitis. This is really an allergic esophagitis that's due, it can be certainly due to food triggers and also aeroallergens. So we've had a terrible seasonal allergy season, and that can certainly be a trigger, just the pollens in the air. It's typically associated with other atopic conditions like asthma and eczema. So these kids often come in with sort of an atopic diathesis, or the family has an atopic history. Once it's been going on for a while, because you have this immune-mediated inflammation of the esophagus that's really lifelong. So once it's been going on for a while, you have what we call fibrosis or scarring of the esophagus. It can make it hard to swallow foods. They can get dysphagia or food impactions. And younger kids may just not be eating very well. So failure to thrive, or they're crying when they're eating, or they're vomiting. And vomiting is something we definitely see with EOE. So, what am I looking for? This is actually an endoscopic diagnosis. This would be a good reason to do endoscopy. So there is really no other way to make the diagnosis. So you need to see not normal. This is normal with a nice, beautiful vascular pattern. You need to see one of these. I can't see the vascular pattern at all. Instead, I'm seeing here linear erosions, these little white plaques, which almost look like Candida, but they're actually eosinophilic abscesses. You can see all these. You see a ringed appearance. Actually, even in this one, a ringed appearance. And then you might see thickening and again, this fibrosis going on in the esophagus, all of which would mean you're vomiting more easily. Under the microscope is where we see all of these eosinophils, the little red cells. These are two different pictures of eosinophilic esophagitis. And it's important to know a normal esophagus actually has no eosinophils. So when you see this many, you're in the world of eosinophilic esophagitis. Another condition I wanted to talk about in older kids is superior mesenteric artery syndrome, which is sort of a fascinating chicken and egg discussion. And I just want to remind everyone about it because I think it can be complicated. This is a condition you see with rapid weight loss. And what happens with rapid weight loss is the fat pad that's between the duodenum and the superior mesenteric artery basically goes away. And what happens is when you eat and blood flows through the superior mesenteric artery to the gut, it basically compresses the duodenum. So you get this compression of the duodenum, which causes pain, and then you get vomiting. And it's this nutcracker effect, they call it. So it's vomiting, but it's only when you eat. And you definitely see this in patients in ICU settings who've lost a lot of weight, because of critical illness. But we also see it with athletes with weight restrictions. So, kids who are sort of intermittently fasting or purging, so wrestling, figure skating, gymnastics crew, you may see this. And then eating disorders, which again, makes it very complicated because the kids aren't eating, that's why it was happening, but now they really can't eat because it hurts and they vomit. So you need to think of it as a secondary phenomena of the weight loss, but now it's perpetuating it and you're seeing vomiting. You diagnose it with an upper GI classically, and this is actually the compression of the duodenum right there. And what's nice to know is if you can drip in liquid foods and then later do a liquid diet, you often will be able to regain the fat pad and stop having the SMA syndrome. So good condition to know about. And then there's Crohn's disease, which obviously mostly will cause colitis, but every once in a while, particularly with a stricturing variant, you may see it present with vomiting. So, if it's going to present with vomiting, it's really a distal small intestine story, not a colitis. And so they're presenting essentially with partial small bowel obstruction. The crack in the sidewalk here is actually the growth curve. And so often what I find is these kids come in and you're seeing a growth curve from the pediatrician's office that really says something was happening. So this is the weight, but you might also see it with the height, just a plateau. It's been going on for a while. Sometimes these kids have been worked up for growth hormone deficiency, and it can take a bit to figure out what's going on. So this is a kid who presented with that growth curve, and actually what we found was this incredible stricture in his distal ileum. And when you scoped him, this was his colon, which looked beautiful, was totally normal. He had no colitis at all. But then here's where the stricture started, or at least for me, where it's actually where it ended. But I'm doing the colonoscopy, I get to the stricture, and all of a sudden I cannot go any further. And again, this went on for a good 10 to 20 centimeters in length. So, there's a lot of other reasons that kids might vomit, and, sort of listed a lot of them here. Don't forget about pregnancy and eating disorders and diabetic ketoacidosis and adrenal insufficiency. But I will tell you, the most common reason I see kids who are intermittently vomiting is constipation. Constipation is remarkably common. 25 to 30% of kids will have, constipation in their school days. And it's one of the things it can do is cause vomiting. So they won't tell you they're constipated, but they do come in. The parents are puzzled. Why do they keep vomiting? And definitely you want to be thinking about constipation. I'm just going to end with something on cyclical vomiting syndrome, which you really can see in children of all ages. This is characterized by episodic spells of sudden vomiting. And again, sort of ominous, but classic is it's really early morning. So it'll happen between 3 and 6 a.m. Unfortunately, with often no prodromes. The kid goes to sleep just fine, but 3 to 6 a.m. they are wide awake and they are just retching and vomiting. And it's a migraine variant. So either the child themselves has migraine, or there's often a family history of migraines. Migraines, of course, being a diagnosis of exclusion. So this is tricky, and you want to get the diagnosis right, but you also don't want to do ridiculous amounts of testing when this is more common than you realize. So I'll talk about that. We do see it in younger kids. People are always surprised, but it's a story of younger kids, but you can see it in older kids. And again, most kids are going to have those symptoms during the night, but it can be at other times of the day. And when you think about it in terms of its relative prevalence related to other GI conditions, actually cyclical vomiting is considered far more common than celiac disease or Crohn's disease. So, really a lot of kids out there with cyclical vomiting. So there are these definitions of cyclical vomiting. You have to have 5 or more attacks over any interval, or at least 3 attacks in 6 months. It's again, this sort of intense, often vomiting that lasts 1 hour to 10 days. So some kids, it's a very quick experience. Some kids, it just seems to linger with intense, horrible nausea. And then in between, they'll have these episodes, they'll have these periods with no symptoms at all. What's that pattern? So is it every 2 weeks, every 3 weeks? That's actually all at the individual patient level. So you really need to be trying to understand if there's a pattern, but that pattern will be very specific for that patient. And they tend to return to their baseline health. So they feel perfectly fine between episodes. So here's a great example of a 5-year-old comes in and you're seeing about every 20 to 30 days. He spends about 2 days just retching and retching and retching, and it's awful and nobody can understand it. And then this is actually a 12-year-old who comes in. So she goes longer between her episodes, but each time there's an episode, there seems to be this very stressful event going on. Her birthday, first day at school, her parents are out of town, she has a soccer tryout. These are what's triggering this, and it's probably cortisol that's triggering it. So sometimes there's a prodrome. Sometimes the kids sort of were like, I really wasn't feeling that great. But a lot of the cyclical vomiting is like, there's no prodrome. They went to sleep just fine, and they just wake up at 3 a.m. and they can't stop vomiting. They often recover with some sleeping. And again, intervals in between, they have this baseline, they feel just fine. And because you don't have the prodrome, the triptans don't usually work. There's usually no time to get in front of it once it's happening. So we're often using prophylaxis, and I and gastroenterologists tend to use either cyproheptadine when they're younger than 5, or amitriptyline when they're older than 5. Do you have to give everybody prophylaxis? No, the kid who it happens every 2 or 3 months, I might say, well, let's see if we can keep them at home with some, ondansetron, or even use the cyproheptadine when it's happening. But if it's happening often enough, it's just nice, because it is very unpleasant really for the family, the child, and sometimes they need hydration, so they're coming in and out of the ER. The differential diagnosis is it's there, so you need to think about, okay, they're waking up, they're having this thing, is it cyclical vomiting, but could it be intracranial pathology? So you really need to make sure you're thinking about that. Could it be malrotation? So some of this workup you're doing sort of it doesn't have to be done in the ER, but you're sort of getting the abdominal imaging, and you're getting the head imaging, thinking about UPJ obstruction, which actually uretero-pelvic junction obstruction, which actually sometimes you can only find it in an episode. So these are kids who need that abdominal ultrasound done as they're having the episode to see that. And I think in 25 years of doing GI, I've picked it up twice, but obviously it can happen. And then there's some metabolic syndromes. So I think that's something really in younger kids to, again, repeat sort of the metabolic serum organic acids, urine amino acids. Yes. And then, you want to be thinking about some of these metabolic defects in the little kids. And sometimes it has to be, the blood actually has to be drawn at the time of the episode in order to really pick up what happens when they're in terrible stress. So, so that, we're talking with your geneticist or thinking about that is important. And then very importantly, with adolescents, we know there's this funny overlap with cannabinoid hyperemesis syndrome, which we can see with chronic marijuana exposure. And it is classically alleviated by hot showers. So these are kids telling you that I feel better when I'm in the hot shower. And definitely there's some thoughts about what that is. There's this concept of using topical capsaicin. But really, what's it all about? It's all about, look, if you've got cannabinoid hyperemesis syndrome, you look a little bit like cyclical vomiting, but you also have a bunch of things that don't quite add up. And most importantly, I can try to give you treatments, but in the end, what this is about is cannabis cessation. So you really need to probe for the cannabis, especially these days, and you need to tell them that's what happens when you have too much exposure, and you need just like alcohol. I mean, it's actually an intoxication, and you do need to stop doing it because you keep vomiting. So, to that point, I think about what's causing the vomiting and trying not to use antiemetics is where most of us should be. But if you are going to use an antiemetic, try to decide which of the pathways you think is most at play. Certainly more than one pathway may be happening. Great discussion is cyclical vomiting probably is some bloodborne toxin of some sort, which may be the H2 blockers may actually help, or sometimes the serotonergic effect may help. But may also be a mechanical discussion. In any case, you can try to go after it, histamine too. And then really you're saying, well, can I decide which one's most dominant in order to decide what's most likely to cause relief? So here I've given you a whole list of different medications, classic doses, what receptor it would be likely to working on, and then what you need to be thinking about, because every time you give an antiemetic, there's potentially some side effect that you don't want to be causing. So great one is erythromycin, which can increase the risk of pyloric stenosis in infants. So to be careful with some of these. Another big one is metoclopramide. I am no fan of metoclopramide. About 30% of kids will have some sort of dystonia and even a tardive dyskinesia-like look. So there's a black box warning, and it's not one to be handing out, really. So that's something to think about. So take-home points, I think there's 4 physiologic pathways that we know of that trigger the emetic reflex, and thinking about those is helpful for trying to sort out why your patient's vomiting. Also helpful is to think about age and the symptom pattern. Is it acute? Is it chronic? Is it cyclical? Bilious emesis, especially in infants, should prompt more evaluation and even urgent evaluation in infants. And then cyclical vomiting syndrome is very common. Constipation is very common. Cannabinoids are more and more common. So really be thinking about those with pediatric causes of vomiting. You may want to document presence or absence of red flag symptoms when patient's telling you that they're vomiting. Again, try to really decide that they are describing vomiting. It should be they should be able to tell you something that makes you realize it is true vomiting. Use those antiemetics conservatively, but if you're going to use them, make sure you're thinking about which one you're using and why. And I've given you a whole host of references. I want to say thank you particularly to the Academy who invited me to give this talk, but also to the Academy who invited me to write a review of vomiting, which let me remember it forevermore. And I wrote that review with my wonderful colleague, Matt Shields, who gave me the picture of his daughter, Karina. And I'll stop there and say thank you to everyone.